From the University of Toronto's Leslie Dent Faculty of Pharmacy, this is the I'm Pharmacy podcast. I'm Mina Tadros. In today's episode, we tackle a crisis that affects millions of individuals worldwide and has reached an alarming proportion in Canada. We're going to talk about the mental health crisis. Mental health disorders have long been a significant concern, but in recent years, the magnitude of the problem just feels like it's escalated, leaving a profound effect on individuals, families, and communities. Like you, many of the listeners, and myself, not one of us has not been impacted or touched by this problem. To comprehend the gravity of the crisis, I tried to look up numbers about how impactful it is. The WHO estimates that 1 in every 4 individuals globally will experience a mental health disorder at some point in their lives. This equates to close to 2 billion people with some quick back-of-the-napkin calculations. In Canada, mental health conditions affect an estimated 20% of the population annually in a single year. That means 7 million people. These numbers highlight the widespread nature of the crisis and underscore its relevance and why we're talking about it today. What I want to explore is, why has the mental health crisis reached such an alarming level? There's many conversations about what's exacerbated the situation. The societal pressures, the pandemic, the stigma that goes along with it. All of these issues seem to confound and make this problem difficult to unpack, but more importantly, make it very challenging to tackle. We know that there's limited access to many mental health services. We have things that work, whether they're medications, therapy, but it seems that access is a massive hurdle that lies in the way. And no one can deny the impact that the COVID-19 pandemic has cast a dark shadow over the mental health crisis. During its outbreak and its aftermath, we heard lots of stories and concerns about the mental health issues intensifying when people faced social isolation, economic instability, grief, and anxiety about what was happening in the world. Studies have indicated a dramatic increase in the prevalence of anxiety, depression, and substance abuse, making this mental health crisis that existed prior to the pandemic feel even worse. As we navigate through this episode, we will try to touch on the multifaceted dimensions of the mental health crisis. We'll try to look deeply at the consequences, exploring potential solutions, and interviewing 2 amazing experts who have tried to be at the forefront of tackling this very problem. We hope that today we can talk about not just the problem of mental health and what's growing, but try to tackle the questions of, why is it a crisis? Is it getting worse or better? And what can be done to improve the health of those living with mental health conditions? To start exploring this topic, I spoke with an expert in the field, Dr. Paul Kurdyak.
My name is Paul Kurdyak. I'm a psychiatrist at CAMH. I am a professor and hold the chair in addictions and mental health policy jointly at Dell Atlantis School of Public Health in CAMH. I'm the lead of the ICES Mental Health and Addictions Program and Vice President Clinical for the Mental Health and Addictions Center of Excellence at Ontario Health.
So this episode, we're trying to explore, what many have termed the mental health crisis. And obviously we've seen a lot of action from policymakers, the creation of ministries of mental health and many different initiatives. And it's politically obviously a very important issue. And I think many of us see it around ourselves. So why is it a crisis? Like, what, for people who aren't familiar, people who say like, oh, this isn't actually an issue. Like, what is the evidence that it is a crisis? And is it getting better or worse? Help listeners understand why this is an issue.
First of all, I want to acknowledge what everybody knows is that mental health has become such a priority. And I think the reason for that is twofold. One is, I think there's very real increased burden and sort of people struggling, particularly during the pandemic, and we'll probably get into that. Teenagers, like what we call transitional age youth, like we all, like my kids are 21 and 23, they're okay, but a lot of their friends are struggling. Yeah. And that's what I'm seeing a lot of clinically. The other piece of this is actually more of a good news story, which is, and this gets into the realm of the political, and this will be a little bit complicated, but when I finished my training in 2003, I was one of only a few classmates who selected psychiatry. And was discouraged to go into it. And the reason for that is because it was such a stigmatized profession. And I think that represents the general stigma associated with mental illnesses and addictions in the society generally. So when I finished my training, I never would have seen an article in the Globe and Mail, the Toronto Star, focused on mental illness or addictions. You just didn't see it. So right now, I feel like we're in the midst of a public mental health moment. So part of the issue related to what we're hearing about, so on the one hand, I think there is something going on in terms of greater mental health need, and we can talk about how challenging that is to measure, but I also think it's really important to recognize that we are in the midst of a public mental health moment that it's really important to capitalize on.
In my work, we've published a little bit on the rising use of medications, which are only one tool in all of this. And, we'll get the media especially asking, like, is this a sign that mental health is getting worse? And my interpretation has always been that this is likely a good news and a bad news story. The good news being that maybe the stigma is being lifted, that people are willing to talk about this, especially because the biggest prescribers are actually family docs, not psychiatrists. But the bad news being that we're giving them a Band-Aid and just like giving them so are you seeing the same thing? Like, is it a good news that we have more people talking about it, but it's bad news because we don't know what to do with them? Or is that a little too simplified of a situation?
So I think that's the general take. The good news is that people are more inclined to seek help. The bad news is there's no system in which to support both the individuals seeking help and the providers who are trying to work to provide that help.
So if the stigma is being lifted and people are talking about it, that's great. But is there, a lot of people talk about the change in society that's causing mental health to increase. Is that a well kind of defined thing, or is that just hypothesizing that people have? Like, is it that people are working more? Is it the financial stress that people are feeling? Like, do those things actually also make things worse, or expectations? Or is it us being on our phones, right? Like, you hear lots of people being like, oh, it's because we're all on social media. Like, how are all of those massive societal changes over the last 20, 30 years?
Obviously I think about this, and what I'm struck with, and I don't know whether it's cause and effect, but that increase in emerge visits for mental health and addictions occurred at around the same time when greater than 50% of teenagers had iPhones in their pockets, and it just went from there. And it's hard for me to imagine, given what we know about, Facebook and Instagram suppressing, true experimental data on the mental health consequences of their social media platforms, that there isn't something there. Then we get to the pandemic when, there was some polling and survey data that occurred over time, and there was a lot of alarmist reactions to the polling. My take on the pandemic kind of bore out, which is those individuals with pre-existing vulnerabilities really struggled. Other people got stressed out, but it's a normal response to a stressful situation. And what we're finding in that polling and survey data is that it's kind of starting to normalize. Yeah. So I think we have to disentangle long-term societal trends that actually increase risk versus acute tsunami events that people respond to and affect the vulnerable, and other people have stress reactions and are actually kind of resilient.
After our discussions with Dr. Kurdyak, it was obvious that one of the major themes and hurdles in developing solutions for mental health is access. To explore this, I talked with Dr. Simone Vigod, who's a professor in the Department of Psychiatry at the University of Toronto and the head of the Department of Psychiatry at Women's College Hospital. Is it an issue of, one of the things that we've been trying to explore a little bit as well is that, and our other guest talks about this a bit as well, and I think you touch on the same point, is that it's an access issue, that everyone wants to see a psychiatrist, and there's just not enough, especially in the province of Ontario or, across Canada. But when they do get access, are our treatments good enough? Or, is it an access and treatment problem, or is it one or the other? Like, how are we, I know it's a lot to unpack, but, maybe you could touch on the issue of is the bottleneck the access, or how good our treatments are?
I think it's all of those things.
Yeah.
So when we think about mental health issues, the most evidence-based way to think about treating them is with a stepped care approach.
Okay.
So when people have, let's say, milder symptoms or are struggling, maybe don't meet criteria for a mental health disorder, but could if things get worse.
Yeah.
We know that, managing psychosocial stressors and, interventions like peer support, interventions like support from, a healthcare professional, like a nurse who isn't even, let's say, trained in counseling per se, can be really helpful. And listen, I mean, that's not to say that every single psychosocial risk factor is modifiable either,
right?
Which is one of the really complex parts, right? I mean, there are complex things that need to happen to help people be less stressed in their lives that don't just have to do with the healthcare system, right? We're talking about poverty and housing and intimate partner violence, right? So all sorts of things there. But there's really good evidence, in the sphere that I work with, a lot of pregnant and postpartum people, peer support, guided self-help has really good evidence to help people with milder or, subsyndromal symptoms, right? So we probably don't do that enough, and there probably isn't enough kind of built into the system to create a good stepped care system, right?
Yeah.
Ideally, if you were having an issue with your mental health, you should be able to call some number and say, these are the issues that I'm having. And then they would direct you to like the right level of care. We don't really have that. And so then for people with, let's say, who aren't responding to those interventions or who have, more severe symptoms, maybe meet criteria for a mood disorder like a depression or an anxiety disorder, evidence-based psychological treatments like cognitive behavior therapy, interpersonal therapy, and now even others, behavioral activation, acceptance and commitment therapy, like, manualized therapies that have been shown in randomized control trials to help people do help a lot of people. Maybe not 100%.
Yeah.
But even if it's 60% or 70% of people, that's a really good number.
Those are
right?
pretty good.
Those are pretty good numbers. Yeah. And so, we have a problem there too, right? Do we have enough people trained in them? Certainly doesn't have to be psychiatrists who deliver those. Highly trained social workers, nurse psychotherapists, psychologists. There are lots of people in our system who can be trained. There's even evidence that people who maybe are non-specialist healthcare providers. So I'm involved in a trial right now taking postpartum nurses and midwives and training them in one of the psychological therapies. So they're healthcare providers, but they're not trained in mental health counseling. And it looks like, there's lots of evidence to suggest that those kinds of healthcare providers can be trained up to deliver just as effective treatment. In Canada and Ontario, though, the way that our health system is structured is the only way to get therapy that's like covered for you, though, is if it's either from a doctor, so a family physician or a psychiatrist, or if you can get it through like a hospital-based program, like some of the family health teams or a hospital-based program. But that leaves a lot of people who can't afford the therapy, which is a huge access gap, right? And then it's an equity gap because then you've got some people who can afford the therapy or have insurance for the therapy. And people think of Canada as a universal healthcare system, but it doesn't cover that, right? And then you get into, okay, well, if that doesn't work, that's when we should be thinking about, the next level up, which is medications. I don't know that there's really an access problem with regard to medications, although, there can be as well there with respect to drug coverage and with respect to, again, it's the family physicians who manage most of the mental health issues. So, so family physicians can be expected to manage first line, maybe second line medications, but still need specialist support to do so.
Yeah. We obviously, family doctors are the number one prescribers of antidepressants, right? Like when we just look at like where people are getting these medications from, we talk about just, the rising number of prescriptions, but it feels like that's just part of the battle, right? Like it's only one of the tools that we're able to give access to. I want to dive a little bit. We held, this is kind of like the timing is kind of interesting. So last week we held a town hall on depression and access to depression, and a family doctor and I, Noah, were answering people's questions. And I was so taken aback by some of the feedback around one, that people were asked if they signed up for any of these behavior programs, if they can commit to it and ensure that they come to every meeting. And the thing that they said to me, and one person that really resonated, was that it's almost like they're ignoring what it's like to live with mental health. And then if I don't show up, which is a symptom perhaps of what I'm experiencing, then I can't get access to this program. And then and I think you touched on this a little bit, like the number of sessions are nowhere near what's actually needed by evidence, right? Like sometimes even if through their private insurance, they get like 3 or 4 sessions paid for, that's not enough, right? Are these the access issues that are kind of holding people back from being able to access these? Or is it just or is it finding them in the first place?
Yeah. I mean, I think that the insurance is a big issue.
Yeah.
Right. And yeah, I mean, listen, when you are very depressed, some of the symptoms of depression are that it's hard to motivate.
Right.
A lot of the research that I do is focused on improving access to care for pregnant people and postpartum people with depression. And so even before the COVID-19 pandemic and virtual care bloomed, we were really involved in virtual care options because we had people saying to us, well, I can't take, I've got to get all my hours in before I at work, like so that I can get my employment insurance when I'm on leave. Like I can't just leave in the middle of the day for 12 weeks straight for this therapy, even if you're offering it to me, right? Or postpartum, well, what am I going to do with my baby and my other child, and it's the winter and I have to bundle them up and get them down. Yeah. And, what if I live in, Barrie? There's no,
it's like the system forgets what it's like to live, right?
Right. Yeah. And so we were working on virtual care type options for quite a long time, including, web-based programs where people could log in 24/7 and post, and it was more asynchronous, which people really liked. And in one of those interventions that we run now across the province, it's called Mother Matters for postpartum depression. We trialed a live chat hour because we thought, people will really, want to do that. The patients hated it. They said, the best thing about this is I don't feel like I'm missing out because I don't feel like I have to be somewhere at a specific time. And so we ended up canceling the live chat hour, right? Whereas for other people having, a live one-on-one, but virtually was more what they wanted. And so, I think their psychotherapy can be really effective, but as you say, it has to be practical and acceptable. To
how people live.
We're running a trial right now for pregnant people with depression who have more severe illness and really don't want to take antidepressant medications in pregnancy for various reasons, and maybe either haven't responded to therapy or, like we were talking about, like can't make it work. We're using a non-invasive brain stimulation device that they can use at home. And we only have to bring them into the hospital one time to trial it out. And then after that, they have 3 weeks worth of 30-minute sessions, and our staff, schedule at a time that's good for them, and they work on a workbook and they do their session, and and it's just 3 weeks. And so there are a lot of innovative ways that we're looking at, that others are looking at, to try to target depression, to try to target anxiety, because the other thing you were alluding to is the same thing isn't going to work for everybody.
Right.
And we need a bunch of different ways to get at this and really make sure that people have effective treatment that is also accessible and acceptable to them. And I think that's a big challenge.
Your specialty and what you think about in your care are women who are pregnant and either experiencing it during pregnancy or after pregnancy. What are the hurdles? Like, talk to us a little bit about how that situation is unique. Because I think maybe I think some of us hear about it, but I think a lot of people don't realize how that affects people, right? Like that stage in their lives and why depression happens during that space.
Yeah. So, as we were talking about before, I mean, depression and anxiety and other mental health issues are really, really common across the lifespan.
Yeah.
There's some evidence that probably related to hormones, women after menarche, after they get their periods, after puberty, are at higher risk of mood and anxiety issues than their male counterparts. Although for males, they may be more at risk of other issues, such as, for example, substance use disorders.
Yeah.
And so, around the time of pregnancy, there's not really evidence to suggest that during pregnancy, there's a higher risk of mental health issues per se, although it can be a high risk period. For example, 30% of pregnancies are unplanned.
Right.
Intimate partner violence can increase in pregnancy. Someone might have been, treated for depression or anxiety before and been on a stable dose of medication, but then become afraid of, what if the medications, passing to my baby and stop their medication abruptly? So there can be reasons why people in pregnancy might like relapse or might have more stress. And then when we're treating them, we have those same considerations like I was talking about before. What about the hours they need to put in to make sure they get their EI, their employment insurance? What about, whether should they take medications or not, right? I mean, most antidepressant medications in pregnancy are relatively low risk, but we can never say that anything is zero risk.
Absolutely.
And then you have the other issue that for family physicians who we were just talking about manage most of the mental health, then you're expecting them to add the, pregnancy and all of the data around pregnancy on top of that.
Right.
So it becomes this kind of specialized period. And then probably related to the massive hormonal shift that happens when somebody goes from the pregnant to the postpartum state.
Yeah.
That is a higher risk time for new or recurrent mental health issues, including severe ones like bipolar disorder, psychotic disorders, but also worsening depression and anxiety, plus the sleeplessness, social support issues, transition to parenthood. So there are some really specific things in the postpartum in terms of the way that things present, like worry about baby, conflict with partner. And so a lot of the therapies postpartum, the psychological therapies have been adapted to that life stage, right? It's not just sort of like a general, the general.
You can't apply what you do outside of that stage.
Yeah, I mean, you can apply it a little bit, but there are some pretty specific issues. And then again, people are worried about if they're breastfeeding, right? Or they're worried about what about medications and pregnancy, lactation. So that's why there are these kind of clinics that have developed that are, we call ourselves reproductive psychiatrists.
Yeah.
And we really specialize in that time period, as well as, what's happening with the hormones fluctuating around the menstrual cycle. And then again, the perimenopause, when people have fluctuating hormones before menopause, can also be a really complicated time that often coincides with, empty nesting from a social perspective, getting closer to retirement, and other psychosocial changes. So, but I think part of the reason why the pregnancy and postpartum has become such a big focus is it's never more apparent than at that time or, when there's a parent and a young child that you're really treating more than one person.
Yeah.
You're treating two people, you're treating a dyad, you're treating a whole family. And it really hits you that this is about treating the person in front of me. And it's also about ensuring the healthy developmental trajectory of the next person. And what's wonderful about that is I think sometimes patients and people really have that increased motivation to make change, might take medications if they'd never done it before because they really, really want to be, they really, really want to get better quickly. Right. So it's a pretty unique time, but the access issues, the issues around drugs in pregnancy, the issues around the kind of therapy that we can give and how to make sure they have time and flexibility to do it. Those are really big issues around that time.
Dr. Vigod is developing some really amazing patient-level interventions. But I wanted to better understand what could be done at the system level. So I asked Dr. Kurdyak about what's being done at the population level in Ontario. Given that the direction that politics is going in, how are they thinking about this problem? Like, are they thinking about it in a way that they think that they're going to solve it? Or are they thinking about this in a way that they're trying to plateau it? Like, is it that the line, if we can imagine a line graph, it continues to grow and we're trying to just like curb it, or are we actually trying to reduce it? Like, let's start there, and then we can talk about potential solutions and things like that exist.
Yeah, I think that I can unpack that in a couple of different ways. I think it's true across Canada now and everywhere that everybody wants to solve the mental health problem. I don't see many people coming up with really coherent ideas about how to do that. Mm-hmm. And that's compounded by the fact that I can just talk about Ontario. We do invest in mental health services in Ontario to the tune of more than $4 billion annually. But we actually don't know enough about that investment, where it's going, what populations are being served, certainly not what outcomes are being achieved, to be able to manage the current investment, which makes it really hard to add more investments without thinking about infrastructure to actually support. And this is kind of vague, but let me tell you, like, pull it back into the real world. If you happen to go to your family doctor with symptoms and it turns out that you have an underlying cancer diagnosis, what will happen without you having to do anything is there will be a series of focused tests to diagnose and stage, at which point that information is sent to the cancer system without you having to do anything. Mm-hmm. A bunch of experts will vet that information and determine the type and intensity of treatment according to existing evidence. Then you go into treatment. Your response to treatment will be monitored, and you will continue getting the appropriate intensity of treatment based on measurement and response. All that happens, and your wait times will be monitored so that your particular experience is not only benefiting from this incredible infrastructure, data infrastructure, performance and accountability infrastructure, but your data is actually contributing to that, so that it's what I would call a learning health system, right? And so that's taken decades to evolve, but I always say the best systems are ones that are unobserved, right? For you as a patient, things should just happen. And in comparison, I field emails and phone calls weekly from people who have family members who are struggling with mental illness, and they go, I don't know where to go. Yeah. And I think about cancer, and I go, like, why is that? So I don't mind at all helping out these individuals. And I think that my colleagues, and I include the diversity of colleagues, all the different providers are doing really great work. But I feel a profound sense of shame that I have to do one-off arm twisting, figuring out for these calls every week or two because there is no system. And so you asked political, but to me, the biggest issue is I think this is an equity issue. We've never invested in the kind of infrastructure to support mental health service delivery that we've done to support the kind of healthcare delivery that we are justifiably proud of in Ontario: cancer care, renal care, stroke care, cardiac care. They've all been the beneficiaries of focused investment. And until very recently, referring back to the public mental health moment, there's never been pressure to invest because nobody cared. Yeah. The public didn't care. Therefore, the politicians didn't care. The bureaucrats didn't care. And so that's why we are where we are, but it's also why I'm incredibly excited. Yeah. So
So is there a political will to not just, have a press conference and say how much money there is, but actually to create that kind of system of excellence? Like, is that the work you're trying to tackle now?
So that is the Mental Health and Addiction Center of Excellence, that is our job.
Yeah.
The simplest way is to build a system where none exists. And our job in doing that, we're working with the bureaucrats, we're working with the providers of all sorts. Like, this is a very collaborative enterprise. Mm-hmm. But yes, it is. The goal is to try to create the infrastructure. In other words, apply the playbook.
Yeah.
To mental health and addictions. And I can't think of any other way to address the issues, because I don't know how else you'd get from A to B.
Where does the emergence of virtual care and apps and things like that play into sort of the battle against mental health? Like, yeah. How is that fitting into the playbook that you guys are developing or thinking about? And has it made it easier, harder? Does it shift things?
I think the answer is both. So first of all, virtual care means a lot of different things. During the pandemic, we saw the whole healthcare system pivot to virtual care, which in this instance is the delivery of individual or group-based care in virtual formats versus in person. I personally, and this is just, we did some work in telepsychiatry pre-pandemic, and it was a very low, there was very little of it going on.
Yeah.
And it certainly wasn't planned in the way that you'd like it to, in terms of going to specific areas where we knew there was low supply. And I don't think we still haven't assessed it to the degree that I would like to, but I think, understandably, there was just a shift in service delivery in a matter of weeks.
Yeah.
But I don't think there has been a reorientation of, say, the FTE complement of psychiatrists to redistribute them virtually across the province. I think people just pivoted to virtual care, right, and did what they do. So that's another way of saying, I think we still haven't extracted all the juice out of the pivot to virtual to maximize access provincially across the province. But I think that there's a huge opportunity. The other aspect of this is apps and other forms of virtual delivery platforms. I think that there is a huge potential for apps. I think that the two issues with apps currently, and I'm not an expert on this, but this is just my high level take on this, is that it's kind of the Wild West. There's a lot of untested. These aren't developed in the same way that drugs are developed.
Yeah, there's no RCTs.
No.
Not many. There's a few, but there's not many RCTs. Yeah, absolutely.
That's right. And so how do you ensure that you're exploiting these? And the potential is huge, but do it in a way that's safe and responsible, right, and ensures that people get what they need. And then the other piece is related to apps. How do you make sure that people do them? Like, I have 100 apps on my phone. I use 5 of them.
Yeah.
And so, those apps are only as good as people use them. We're talking about trying to get at individuals for whom motivation is low to begin with because they're struggling with mental illness. So I think there's a lot of work. There's a lot of promise, but there's a lot of work to be done. And then the final area is the modification of evidence-based treatments, which I think is very promising. So, for example, internet-based cognitive therapy is a very unique form of app-based care where we are integrating that into our provincial CBT program so that it's an even lower FTE burden because there's a coach attached to the app, but people are doing a lot of the work of their own. But the coach is monitoring, and the idea is that the coach increases uptake by sort of improving motivation and making sure that people are moving along, and also monitoring response to treatment and pulling them into more intense care should they need it. So that was a lot. So there's the whole, how do we optimize our mental health human resources in virtual delivery of care?
Yeah.
How do we optimize evidence-based treatments like internet-based CBT so that we get a volume proposition that we know is evidence-based while we wait for the other app-based stuff to evolve, and how do we impose a evidence-based regulatory framework on those things so that we actually know they are safe and work.
It was exciting to hear about the system level changes and the emergence of digital health in this space. But what was holding us back? I spoke with Dr. Vigod about this very issue. Where's the challenge? Because, we see politicians up there promising billions of dollars for mental health, and that they're gonna, you would think that these are if you show that something works, they should be investing in scaling it up. Where does it fall apart?
Well, you just met with Noah Ivers. I mean, I think where it falls apart is in implementation.
Yeah.
Right? And is in the connection between research and, and implementation and sustainability.
Right.
The fix is not small, right? I mean, the fix requires governments to commit to implementing,
mm-hmm.
to commit to change. Change is hard.
Right.
Right. I think, Ontario is moving toward a system-wide, if you spoke with Paul Kurdyak, Ontario is moving toward a system-wide implementation of, access to some evidence-based psychotherapies, which is a really big thing.
Yeah.
But, change is hard when you've got your providers kind of on the individual level treating individual patients.
Yeah.
To actually change the system of what they're doing. Also, the bigger trials, the bigger implementation trials, it requires a huge investment.
Right.
It's really tough to get really big kind of the way that we'd want to do it is we'd be wanting to actually implement something, even do a trial on a whole system level.
Right.
To demonstrate that we can implement it. We can implement for all types of groups. What do we need to do? What do we need to change? Is it cost effective?
Yeah.
And that's investments of millions of dollars. It's probably the way to do it right, because then once you do it right and it works, then you've actually got the system implemented.
Or you can even think about scaling from the beginning. How do you actually, I think that's the problem, right? There's too many questions about, there's lots of great things that people could be doing, but I just, I think.
Yeah, I mean, and I think it's more than, people say that about Canada, the land of the pilots, but it's more than pilots. We've done and others have done. We know what works for a large part in mental health. But there's a large gap between what we know works and what we are doing.
Mental health is complicated. But I can't help but feel hopeful that the tide is turning just a little bit. We have the treatments and we know what works. And we finally have political will, large investments, a willingness to shift systems to match the demand and need from the populations. But I don't want to downplay the problem. The problem is big. On a population level, we've heard the extent of what is affecting us. But I do feel like the time is now, and I really do think we don't have a choice. This episode of the I'm Pharmacy podcast was produced by Steve Southon, Kate Richards, and me, Mina Tadros. Musical accompaniment was from Steve Southon and Diego Martinez. This episode was edited by Steve Southon. Special thanks to Dr. Paul Kurdyak and Dr. Simone Vigod. Just a quick reminder, make sure to subscribe to this podcast wherever you listen to podcasts. And if you don't mind, leave us a 5-star review. We'll be dropping new episodes every single month, so make sure to subscribe wherever you listen to your podcasts. Stay safe and keep asking questions. Catch you at the next episode.